This is our last lecture on psychological disorders, and an important starting point is figuring out how we define a disorder and what is normal versus abnormal. So we define a disorder as a harmful dysfunction, which is behavior that is judged to be either unusual or atypical. But just being unusual is not enough in and of itself, because you can have rare behaviors that are positive as well. So psychological disorders also involve behavior that is socially deviant. Now, how we define that varies with time and culture, but it's something that is kind of socially unacceptable. It's emotionally distressing, so it causes excessive and prolonged emotional distress. It's maladaptive, so it causes kind of personal distress, causes problems in someone's health or social or occupational status. It's dangerous either to themselves or other people, or involves some kind of faulty understanding of reality, delusions, hallucinations, believing things that are not real. So in psychology, the main criteria that we use to diagnose a disorder is the American Psychiatric Association's DSM, or Diagnostic and Statistical Manual of Mental Disorders. And so it's a system for classifying disorders. You've got these different categories. There are definitions, although it's important to remember that the definitions kind of are culturally specific, so they're based on Western cultural norms. But these tools are used and developed by both psychologists and psychiatrists. They're research-based, and they're constantly being revised. So this is the 5th edition that we are currently in. We've got these discrete categories that we use to kind of define a disorder. Either you have a disorder or you don't, but kind of one criticism of the DSM is it's important to remember that disorders happen along a continuum. So this is kind of one of the downsides of using this, but it helps us kind of categorize them, disorders in terms of treatment, charging insurance, things like that. So it's important to remember that disorders are very common. If you haven't personally experienced a psychological disorder, someone you know has. So by some estimates, 1 in 4 Americans have a mental illness. You can see kind of the top figure is the lifetime prevalence of anxiety disorders, mood disorders, impulse control, and substance abuse disorders. Down below you have the age of onset. So some of these disorders start in kind of early adolescence. Others are more likely to start later on. And so we're going to go through a couple of categories, a couple of types of disorders, and we're going to highlight those. So the first is anxiety disorders. So we define anxiety as a diffuse or vague concern that something unpleasant will soon occur. And it's important to remember that this is excessive given the situation, or it interferes with your ability to function. And so it being excessive or interfering with functioning is what makes it abnormal, what makes us classify it as a disorder. If this kind of reaction, anxiety, intensifies or persists for a long time, then we may classify it as an anxiety disorder. And some components of this are that it's irrational, so that the threats are exaggerated or non-existent, and the anxiety is out of proportion with reality. The anxiety is uncontrollable, so you can't just shut it off or shut down the alarm, and it's disruptive. It causes problems to individuals' relationships and jobs and everyday activities, and anxiety disorders are one of the most common categories of disorders. So we'll talk about a couple different ones, starting with generalized anxiety disorder. So with generalized anxiety disorder, the individual is tense, apprehensive, and in a state of autonomic nervous system arousal, so that's fight or flight response. It's excessive, global, and persistent symptoms of anxiety. So this isn't anxiety about a specific object, it's just all the time, this free-floating anxiety, this feeling that something bad is going to happen without a specific fear in mind. Next is panic disorder. Panic disorder involves periodic, unexpected attacks of intense and terrifying anxiety. This is essentially periodic panic attacks. So these attacks involve physical symptoms like a racing heart, rapid breathing, breathlessness. Some people report feeling out of their body or like they're going to die or lose their mind. And sometimes these take place in specific situations. So, in terms of the frequency, they can last one or more times a week. Some can last for minutes, some can last for hours, and often they occur kind of in unexpected situations. So what happens is, especially if these are triggered by a specific situation, people start avoiding the situations that lead to panic attacks. And so panic disorder is associated with a disorder called agoraphobia. So this literally translates to a fear of crowded or open spaces. But what this often is that people are afraid to have panic attacks in front of other people. And so they start avoiding any kind of situation where they might see other people or have a panic attack triggered. And so what often happens is these people are stop leaving their houses for fear of these panic attacks. So in terms of what might cause the panic disorder, there's certainly a genetic component. So panic disorders run in families. We have higher rates in identical twin pairs than fraternal twin pairs. There's also some evidence for kind of brain chemistry. It seems to be associated with the noradrenergic system. And basically when this system is stimulated in monkeys, it leads to a panic attack. And so the thought is that people with panic disorder may have increased activity in this area of the brain. But there's also cognitive factors. And so the thought is that maybe it's kind of a combination, and what happens is these individuals misinterpret their bodily sensations. So these might be people who are biologically predisposed to anxiety. They don't feel like they have a lot of control over what's happening in their lives or what their body is doing, and they're oversensitive to physical sensations. So maybe walking from their car into the store makes them out of breath. Rather than just saying, oh, it's because I was walking, they say, oh no, it's because I'm going to have a panic attack. And then that tends to kind of cycle with the way they think about and interpret those physical sensations, which can lead to another panic attack. And so these people often have kind of this triple predisposition of the biological, the low sense of control, and the oversensitivity. Okay. Next, still in this anxiety category is phobias. So phobias are intense and irrational fears of objects or events. And so these normally fall under the specific phobia category, where it is about something particular as opposed to general anxiety disorder, which is just this general sense of foreboding. It really, this is a fear of something in particular that impairs an individual's ability to function. So common phobias are animals, snakes, spiders, things like that. Specific environments, illnesses or injections, certain situations like travel or small spaces, social events, things like that. And the key that kind of distinguishes a phobia from a fear is that a phobia is so intense that it interrupts someone's daily life and is out of proportion with the object or the situation. So in terms of how phobias develop, there's a lot of evidence that phobias can develop from learning. So if we go back to our learning chapter, we think about classical conditioning. If you remember the little Albert experiment, Watson was all about creating fear by pairing an unconditioned stimulus with a conditioned stimulus. So if you have a bad experience with something, you may develop a phobia of that thing. Operant conditioning is about being punished or rewarded for something. So maybe someone was excessively punished for something when they were a child and that led to a phobia. Or observational learning, where maybe you witness something bad happening to other people and that can lead to fear. But there's also some evidence that these can be physiologically based too. So it seems like people who are more prone to phobias have excessive physical arousal. They have a really high startle response, which is kind of an innate and biological response, and those people are more likely to develop phobias and anxiety. Okay. Moving on, trauma and stress-related disorders in the latest DSM are kind of their own category, but the most well-known one is PTSD, or post-traumatic stress disorder, and this is basically an extreme response to a very severe stressor. So this can be war, traumatic abuse, a spree shooting, a terrorist attack. I mean, this is way outside of the realm of people's typical experiences, but often it involves a sense of helplessness during the original event. And symptoms involve intrusive and frequent unwanted recalling of the event that interferes with normal thoughts. People avoid the stimuli associated with the trauma. And again, this is to the extent that it interferes with their life, and increased anxiety and emotional responses. There's also acute stress disorder, which is similar. Acute stress disorder is these kinds of symptoms that last less than 6 months. PTSD is when it lasts more than 6 months. So in terms of risk factors for PTSD, of course, exposure to a traumatic event or multiple traumas is part of the definition. Perceiving a threat to life during this experience. Women are more likely than men to experience PTSD. Some kind of family history, so early separation from parents, as well as kind of this genetic component of a family history of disorders. And then pre-existing disorders. So for example, someone who already has an anxiety disorder and experiences some kind of trauma is much more likely to also have PTSD. Okay, next is obsessive compulsive disorder. Obsessive compulsive disorder involves unwanted and repetitive thoughts, which is the obsessions part, and or actions, which is the compulsive part. So this can be pursuing cleanliness and orderliness, avoiding particular objects, performing repetitive or magical or protective practices, repeating certain numbers, checking and rechecking whether the oven's on or things like that, or performing a particular act. And so part of this definition is that the obsessions have little to no basis in reality. They're kind of far-fetched, right? So if the obsession is about leaving the oven on, they're very worried about that, and they're worried that leaving the oven on is going to burn down the house. While it's probably not great, the odds of, even if you do leave the oven on all day, it actually burning down the house are very small. So those are the thinking part. The compulsions are ritualistic, and so they involve kind of a certain pattern or sequence. Sometimes compulsions are overt and physical, so this can be things like hand washing, only stepping on every other stair, things like that. But sometimes they are kind of covert and mental behaviors. So sometimes counting behaviors in OCD, or reciting things to themselves, are compulsions as well. So there's about a 1 to 2 prevalence rate in the general population for obsessive compulsive disorder. In terms of explanation, if we think about kind of Freud and the psychoanalytic view, Freud basically argues that these kind of behaviors are from when people get stuck in the anal stage. So they had something traumatic happen during that stage, and that's what leads to it. Not a ton of evidence for this. There is evidence, though, for conditioning. So the behaviors are learned, and what happens is the compulsions are learned because they reduce fear. So it's this cycle of negative reinforcement. If somebody is obsessed with germs, then washing their hands reduces the anxiety momentarily, which makes them more likely to do it in the future. And eventually, rather than washing their hands, once every 2 hours, they're washing their hands once every 5 minutes. There's also a lot of evidence that OCD is kind of biologically based. So sometimes things like head injuries or tumors can actually trigger OCD. And there's also some evidence that it's associated with serotonin. So antidepressants, which increase the availability of serotonin, seem to decrease OCD symptoms. Okay, next are depressive disorders, another very common category. For depressive disorders, individuals to be diagnosed need 5 of the following 9 symptoms. They need to have at least one of the first 2, so a sad or depressed mood most of the day, every day, or a loss of interest or pleasure in usual activities. But then you can see the rest of the symptoms are kind of emotional, physical, behavioral. There's a lot of different ones, and some of them are opposite, right? So depression can show up as difficulty sleeping or sleeping all the time, poor appetite and weight loss, or increased appetite and weight gain. but an individual has to experience at least 5 of these for at least 2 weeks. And major depression is the most prevalent of mental disorders, so 5 to 17% people experience it in their lifetime. That's a pretty big discrepancy, and a lot of this has to do with kind of diagnostic criteria and things like that, which criteria people actually use to diagnose it. But depression is much more common, 2 to 3 times more likely in women than men. Also, people with lower socioeconomic status are more likely to suffer. And depression is a recurrent disorder. So 80% of people with depression experience another episode. Most people average about 4 episodes within their lifetime, and each one of these episodes lasts 3 to 6 months. There's evidence that without treatment, these depressive episodes tend to last longer, and recurrence is more likely and more severe. In terms of causes of depression, again, start with Freud, not terribly well supported, but basically the psychoanalytic theory would argue that during the oral stage, a child's needs were insufficiently or over-sufficiently gratified, causing some kind of fixation on this stage. So they become overly dependent on people for self-esteem, and then they have anger, which is turned inward. I think the more common view are either cognitive behavioral or neurochemistry. So in terms of this cognitive thing, the argument is that individuals experience stressful experiences. They have a negative way of explaining it. So I'm a bad person, things always go wrong, this is permanent. That leads to a depressed mood, which leads to more negative behaviors and cognitions, which kind of creates this cycle of every bad thing that happens makes the depression and the negative thinking worse. So this can kind of feed into this idea of learned helplessness, where maybe people make an attempt to try to change things and make things better. It doesn't work, and so eventually they give up. So they get this depressive attribution to style. But there's also evidence for neurochemical supports for this. So people with depression have lower levels of serotonin. And so, for example, SSRIs, which are a category of antidepressants, block the reuptake of serotonin, which makes it more available in the brain. So that serves to reduce depression. Next is bipolar disorder. So bipolar disorder used to be called manic depression, but it involves wide mood swings from depression to mania. So mania involves kind of rapid speech, a reduced need for sleep, increased impulsivity and scattered behavior, and kind of this inflated self-esteem. And so often these manic episodes last a week. They're present most of the time. And so these are people who, all of a sudden think they're gonna, solve a problem or save the world. They don't need to sleep. They become so fixated on this idea. And they're doing risky things, spending a lot of money, those kinds of things. And so they cycle through, and it's not kind of immediate. Normally these cycles last a week or 5 days, or potentially longer, between these manic episodes and these depressive episodes. So the prevalence rate is 1% of the population, more common in women. Like depression, bipolar disorder is a recurrent disorder. 50% of patients have 4 or more episodes. 12 months, so a year after leaving the hospital after being hospitalized for bipolar disorder, 76% of patients are still rated as impaired, and 52% still have the diagnosis. And so this can be kind of a very difficult disorder to live with. There's some evidence that it's driven by genetics, although it hasn't been narrowed down to one specific gene. Okay. The next group of disorders is dissociative disorders. So dissociative disorders in general involve disorders in which conscious awareness is kind of separated or dissociated from previous memories, thoughts, and feelings. In general, these disorders are pretty rare. Particularly this first one, dissociative identity disorder. So in dissociative identity disorder, a person exhibits 2 or more distinct and altering personalities. So this used to be called multiple personality disorder. prevalence is very low, and this is really a pretty controversial diagnosis. Cases really increased dramatically after the book and the movie Sybil came out, and so the argument is after this well publicized case, all of a sudden people are getting diagnosed with it. Maybe it's not actually happening as much as we think. There's a lot of skepticism, but there are some well documented cases of this. In terms of causes, the argument here is child abuse can lead to kind of extreme dissociative coping. It's hard to test this theory because our memories are unreliable. The argument here is that individuals who experienced extreme child abuse kind of separated the parts of themselves that were traumatized, but if they don't have those conscious memories, it's hard to test them. Another theory is social role enactment, where kind of you might believe that you should be the perfect employee, but you also want to, be wild and crazy, and so this can be, those get separated into two actual different personalities. And so sometimes these are motivated by therapists, sometimes other things, but that's another potential explanation. This is pretty commonly comorbid with depression and borderline personality disorder, and has a number of negative outcomes, like suicide attempts and self-abusive behavior. Okay, a more common one is schizophrenia. So schizophrenia is basically involves fragmentation of basic psychological function. So the literal translation for schizophrenia is split mind, and it's characterized by disorganized and delusional thinking, distortions in perceptions, and inappropriate emotions and actions. Okay, so there's two general categories of symptoms for schizophrenia. The positive symptoms are normally what we think of. These are excess or distortions. So this can be delusions, so false beliefs. So often these false beliefs have to do with persecution or grandeur. So people think they're God, or they think the mafia is out to get them, and they continue to believe these things despite contradictory evidence. Sometimes there are also hallucinations, which are false or distorted perceptions, so hearing voices or seeing things that are not actually there. And then also disorganized thoughts, speech, or behavior, kind of a jumbled manner of speaking where words are put together even though they don't form meaningful sentences. So these are like the more acute part of schizophrenia, but there's also the negative symptoms, which are behavioral deficits. So people with schizophrenia sometimes show flat affect, where they just really show no emotional response whatsoever. Avolition, which is a lack of energy. They're kind of apathetic, will just sit and stare for hours at a time. And then alogia is poverty of speech, where you kind of have very limited verbal responses. So you can't diagnose people without the positive symptoms, but some people only have positive symptoms and don't have the negative symptoms. And in general, people who also have negative symptoms generally have the worst prognosis because the negative symptoms are harder to treat. In terms of onset and course, schizophrenia is something that's chronic. It's not something that comes and goes. It's always there. It generally begins kind of in the early 20s, often starts following some kind of stressful life event. And in terms of causes, we know that there's certainly a genetic component. So being related to someone with schizophrenia makes it much more likely that an individual will develop it. But even so, only 13% of people whose parents have schizophrenia go on to develop it. So it's not only genetics. Genes kind of create this vulnerability, but don't necessarily determine it. We also know that dopamine plays a really big role. So drugs that reduce dopamine activities release or reduce symptoms. Paternal age. So often seeing new cases of schizophrenia with no family history are much more likely when the father is older. And so the thought is that there's some kind of random genetic mutation that increases the likelihood of this. There's also a theory about the immune system, and the idea is that exposure to some kind of viral infection prenatally or in infancy could potentially spread to the brain and spinal cord and kind of alter antibodies in the blood cells that actually influence these individuals much later in life. Unhealthy families. So we know that families in which there is kind of psychological disturbance, people who are the victims of abuse are much more likely to develop schizophrenia, especially if they also have a genetic risk. And stress is also a significant component. So we see higher rates of schizophrenia in areas with higher stress, so people of lower socioeconomic status. And often there's kind of this combination between stress and genetic risk. Okay. Next, the final category we're going to talk about are personality disorders. And so these are excessive patterns of behavior that make it hard to adapt in daily life or form long-term relationship. And basically these are extreme variations in personality. So these are behaviors that are consistent over time and across situation. They're inflexible, maladaptive. These are kind of normal traits taken to the extreme. And there's a couple of distinct clusters. I'm just going to select a few to go over and discuss. So paranoid personality disorder is individuals who are extremely suspicious of other people. They kind of expect to be mistreated and react angrily to others. So they become really suspicious of people close to them, and they blame them for their shortcomings. When other people point out that their concerns don't make sense, individuals with paranoid personality disorder see this as kind of further evidence to support that. This is kind of more common in men than women, but it's not paranoid schizophrenia because it doesn't have other symptoms like delusions and negative symptoms. Next is antisocial personality disorder. People with antisocial personality disorder show a consistent lack of empathy and remorse. They fail to conform to kind of social norms. They show this blatant disregard for the rights of other people. They don't show distress about hurting other people, and they have no problem whatsoever deceiving or manipulating other people for personal gain. So they, in both childhood and adulthood, they do things like lying, stealing, destroying property, being physically aggressive. And in the general population, it's about 4% of men, 1% of women, and it becomes kind of more common in late adolescence and early adulthood. But one place we see a lot of antisocial personality disorders in prisons, and 40 to 75% of prisoners are reported to have antisocial personality disorder. And this one is really difficult to treat because it just makes these individuals better at manipulating people if they learn about how they're supposed to feel. Okay, the final one we'll talk about is borderline personality disorder. And so borderline personality disorder involves a lot of impulsivity and instability in relationships and mood and self-image. So these people often have really stormy relationships, dramatic mood swings, difficulty controlling their emotion, and really unstable self-image. So there's kind of a broad range of symptoms. They have inflated self-esteem, exaggerated emotional displays. They're impulsive in relationships, and argumentative and irritable and very quickly offended. So these people score really high on neuroticism, which is emotional instability. Normally it begins in early adulthood. Prognosis is not good, so in a 7-year follow-up, 50% of patients still have the disorder. It's also common for borderline personality disorder to go along with other mood disorders like depression. And the prevalence is about 1 to 2%. It's much more common in females, but one reason that this disorder is worth focusing on is that 8 to 10% of individuals with borderline personality disorder complete suicide. So this impulsivity and instability in mood seems to be really related to suicide risk. So in terms of causes, it's genetic. It runs in families, related to neuroticism, which is a trait we know is highly heritable. It also seems to be associated with kind of impaired frontal lobe functioning because they can't control their emotions when they're feeling strong, or their impulses when they're feeling strong emotions. But it really seems to be kind of a diathesis stress, meaning that a genetic predisposition to emotional sensitivity and impulsivity, in combination with a stressful environment that maybe invalidates person's wants or feelings, or where people aren't taught to regulate their impulses, are what creates the greatest risk. So often it's kind of this genetic risk, some plus some kind of stressor. It's also associated with childhood abuse, and that combination increases the likelihood of an individual developing borderline personality disorder. So that is all the disorders we will talk about in this chapter.